So yeah, I work down the street. We've been doing this for a couple years now, actually about 3 years, and it's I think a pretty interesting way to do something that we've been doing for a long time in just a slightly different way. But in terms of this talk, it'll be pretty general of an overview here. But first, I'll just kind of say what this laser interstitial thermal therapy is, just some of the basics in case you haven't heard about it. Some of the indications that people are using it for, some of the relevant anatomy for this procedure. I'll go through a case that just kind of shows how this works, and then talk a little bit about why we go through all the trouble of doing this in terms of outcomes, both for seizure freedom and for preservation of cognition. So first, laser interstitial, you can't say this word, so the laser procedure. Basically, the underlying principle is that light can be used to thermally ablate tissue in the brain. Basically, if you reach 60 degrees, cells die, and for various reasons you want this to happen, you can use a laser. The actual technology to do the laser part of it has been around since the 70s and 80s, and people have written about using it for neurosurgery. I think the thing that really made it worthwhile is the MR thermography techniques that have improved in terms of, and it's not that they couldn't do it, it's just that it took a long time, but with the stronger magnets you can actually get, it's about 0.3 hertz, or yeah, something like every 6 seconds you can get a picture and tell you in near real time what you're actually destroying. And so that's kind of what made this more useful than radio frequency or some of the other techniques that people have used in the past. Right now there's two clinical systems in use. One is the Neuroblate, which is from Ontaris. It's a 1064 nanometer laser. It's a gas-cooled system. They have a variety of catheters that you can put in, and some of them are directed, so you can try and better shape your lesion. We use the Visualase, which is just a straight catheter, a couple different sizes there, and that's a 980 nanometer laser, and that is cooled with saline. The reason you want to cool this is that you don't want your tissue sticking to the laser, and so they're usually in some sort of sheath, and the temperature is regulated somewhat using those cooling systems. The nice things about using a laser is that your lesions are very well circumscribed, and so over here, sort of, I think this is a light, right? Maybe. Oops. In any case, sort of the bottom left there, you can see ablated parahippocampal gyrus, and there's sort of a peel boundary between that and neocortical, the neocortex near there. And so you get a very well-defined area that dies. If you look at comparable, I didn't have time to pull this up, but if you look at old radio frequency lesioning pictures, you can see that there's sort of a gradation of tissue damage, whereas this is pretty much stops where you hopefully want it to. The other nice thing is that the MR estimates of damage, sort of the upper frames there, you can see the real-time imaging is over on the left. You get this sort of heat map. The orange is what is estimated to be your permanent damage. So that's the tissue that's reached 60 degrees. That's what's dead, isn't coming back. And if you look at postoperative imaging, that's a really grainy picture, but you'll get better ones later. But the guess that the MR gives you is actually it's quite accurate, and it tends to stay stable over time as well. And so you're not going to get a lot of change in the size of your lesion, which again is good. So in terms of indications, people do this for various reasons. Intractable partial symptomatic epilepsy is what we're going to talk about today. This can be from a lesion like a DNET or something that's a tumor. We do a lot of this for mesial temporal sclerosis. And we have been doing it in people who are MR normal as long as we can pretty confidently lateralize and localize the lesion. One of the first sort of studies was in children who had hypothalamic hamartomas. You can imagine how that would be pretty justifiable, trying to get down to the third ventricle. It's a pretty long way, and so this laser catheter gets there pretty easily, and you can avoid a lot of the morbidity associated with those open procedures. Actually, most of the early stuff was on tumors, so intrinsic tumors like glioma, glioblastoma, some metastatic lesions, and people have also used this to treat radiation necrosis. So we'll talk about mesial temporal sclerosis. In terms of the relevant anatomy, I think you've pretty much covered all of that in the previous talk. But one of my mentors used to always say everything in the brain is shaped like a C. And so When you're talking about epilepsy, you're going to talk about the limbic lobe. That here, kind of defined here, you can see, wish the laser pointer worked, but this is a picture from Duvernoy that I'm sure everybody is well familiar with. But you have your subcallosal sulcus going to cingulate sulcus going around to subparietal, anterior calcarine, collateral sulcus, rhinal, and entorhinal sulcus there. But the portions you're interested in would be the amygdala and hippocampus. The hippocampus itself also kind of shaped like a C, and so that's important when you're thinking about this in terms of planning your operative approach. All of these catheters are straight. We haven't quite figured out a way to make a catheter follow a curve in the brain reliably yet, so when you're approaching this, you're going to leave some stuff behind. And again, depending on where your epilepsy is localized, you may want to leave more tail, we may want to leave more head. You may want to go a little further forward to get amygdala, but then you worry about Myers loop and things like that. So those are some important considerations. I won't belabor that too much. This is a quick coronal view of the hippocampus, so you can see, again, I thought this was a laser, but I guess not. Maybe that? No. Okay, guess not. The structure you're going to be aiming for in these cases is hippocampus. It's going to be sitting right above parahippocampus, and medially you're going to have ambient cistern, and laterally the temporal horn. There's structures in the temporal, the roof of the temporal horn that you want to avoid heating up, and so in terms of localizing your laser catheter, you want to make sure you're fairly central in the hippocampus. Just out on an MR, you can see it's pretty close to that schematic. So you can see the structure of the hippocampus there. There's a little asterisk on choroid plexus there. The hippocampal sulcus has those little arrows. You can see collateral sulcus there with a double arrow. Oh, great. Okay. Yeah, so I guess it doesn't work all the way over there. That's really not that useful. Thanks anyway. Sorry. In any case, those are the sort of structures you use when you're planning the case, when you're looking to see whether you're in the right spot with the laser catheter. To quickly go through an illustrative case, I'm going pretty quick here, but in terms of epilepsy, this is your sort of standard workup. So you do video EEG, long-term monitoring. The reasons for doing this, you want to make sure that the person has epilepsy. You want to make sure that you have correct lateralization, that you're not doing surgery on somebody who's going to later develop seizures on the other side. And you get a high field MR. Again, this shows whether or not they have mesial temporal sclerosis. You see a sclerosed shrunken hippocampus. It gives you a better idea that this will work. If you see some other lesion, that's usually generally helpful. Basically, if you have something on MRI, that's good. It bodes well for prognosis. If you don't see that, you can do adjunct tests such as an interictal PEC or an ictal SPECT scan, but basically these are nuclear medicine studies showing changes in perfusion either with a seizure or when you're not having a seizure. And that can be useful if you're a little equivocal on your EEG, or if you're seeing spikes on both sides, or just, is this really, yes?
A lot of people have seizures.
Yeah.
But not everybody gets surgery.
It's true.
A very small percentage actually gets surgery. I know as surgeons, like operating on it. But can you make a little comment, because it's just the beginning of this, we're going to talk about who is appropriate
for considering this type of surgery?
Yeah, who's appropriate? For even having a sense of, they have
Yeah.
One seizure and that's it, versus somebody who has 10 a day or controlling medicines. How does the surgeon decide, we better work this one off, this is something we might be able to solve, versus all these other people that have seizures?
Yeah, so in terms of surgical epilepsy, you're generally going to want to make sure they're not treatable with medications. So if you can give somebody a pill and their seizures stop, doing surgery on them is destructive no matter how you do it. And so it's not worth it. I'd say about 25 to 30% of folks with a temporal type seizures are going to be medically refractory. So and I'm blanking on the exact percentage that are temporal in terms of etiology for seizures, but it is a minority of patients, but it's a sizable minority. In terms of workup prior to talking to us. Okay.
So you have a guy who has temporal lesion,
Yeah.
and he has seizures,
hmm
but you can see the temporal lesion.
I would still try medications. So about 90% of people will, if just in general with epilepsy, if you put them on Keppra or Dilantin or one of the sort of first choice drugs, their seizures will be controlled for a long period of time. A lot of times you do become refractory later, but if you're controlled with a relatively well-tolerated medication, then you wouldn't consider surgery. If you look at who becomes refractory or how you define being refractory to medications, basically you try one, you try another. If you're failing on 2 drugs, the chances of the third drug making you seizure-free drops pretty quickly. So your first go around, and second go around, you get about 90% of people controlled. But if you can't, then about 4% per new regimen will become seizure-free. So 2 to 4%, depending on which series you read. But there's case series with thousands of patients. The biggest one out of England, I can't remember the name of the author, but they're saying about 2 to. So if you've tried 3 and you've failed, basically, you're not going to become seizure-free. The workup at that point, again, sort of depends on the etiology. If you do have a temporal lesion and you look at it and you think, look, you have maybe a DNET, a ganglioma, something like that, then you may not even do all of this particular workup. You do want to make sure they have seizures, so at least an EEG of some sort, looking either for spikes if it's a spot EEG, but usually we end up doing long-term monitoring on people just to make sure you're capturing the types of events that they call seizures are seizures. And so they used to call psychogenic epilepsy. Now it's just non-epileptiform seizures, but people will have events that it's out of their control, but they're not from epilepsy. And that doesn't mean that they shouldn't have surgery, but you should have several conversations with them, their family, like, look, these events are not going to be treated, but these other ones, these are seizures. These will, the reason we're doing this is to try to make these better. So in terms of epilepsy surgery in general, we're usually not making these decisions in a vacuum, so we should talk about maybe most of this information we compile, we review in conjunction with neurologists, in conjunction with neuropsychologists. So, and we have a weekly epilepsy conference where we're reviewing all the potential surgery cases, including some of the non-surgical cases as well, just so we kind of have an idea of which patients we'll be seeing, sometimes for responsive neurostim or vagal nerve stimulators. Those aren't considered surgical patients, but you're doing some sort of palliative therapy. So we do review all this information for these people. And so most of the time you're not stuck with the decision just, oh, well, they have a lesion, they've tried one medication, what do we do next? I mean, you should know sort of the algorithms, but you're hopefully making these decisions in conjunction with an epileptologist who's going to follow the patient and adjust their medications afterwards. Because again, even with these therapies that work a lot better than medications, there's a sizable percentage where you do the surgery, everything seems to line up, you do the surgery, and they still have seizures. And so that's an important point to make, and I'm glad you brought that up. So to continue, again, most of this workup, a lot of this, you'll be seeing these patients while this workup is going on. You'll be reviewing their data, and so it's usually not all packaged up and saying here you go, but you're getting bits and pieces of information, and if you have doubts about whether or not this is appropriate, you can kind of sort that out through the process. So neuropsych testing, NPT, that's again, that can aid in lateralization. So again, if you have somebody who has an MR, who's MR normal, meaning you look at their scans, you don't see any lesions, their hippocampus looks normal size. If you do an extensive cognitive workup, you can sometimes find deficiencies that go to one side or the other, and that can be helpful as well. And it also gives you an idea, because you are ablating brain. If you do a temporal lobectomy, if you do this procedure, you're taking brain out, and that brain does something. And so it's also good to have a sense of where they're starting out. If somebody's completely perfect and it's a left dominant lesion and they're MR normal, you may want to think twice about taking their hippocampus, because you know they're going to take a hit. If somebody's had seizures for 50 years and their verbal memory's shot and they're MR, I mean, it's not likely, but let's say they are MR normal, you might be more willing to say, okay, we'll try a laser, just because what do they have to lose? And so the greater concordance there is between these tests, the greater their chance of seizure freedom. And so that's why sometimes even, and you'll see in this case, even though it seems pretty straightforward, we still do most of these. So to go over a case, it's the patient we did probably about, I think one of the first ones I did after coming back. It's been about 2 years, but he's a 59-year-old gentleman, had epilepsy for over 20 years. I forget exactly when if he had any predisposing factors, but he was taking 4 medications when I saw him, still had about 4 to 5 seizures a month. He did not have GTCs, but they were just a complex partial. He'd been monitored several times. Some of them had been somewhat equivocal, so he had seen some interictal activity from the right side. So there was some question whether this is a bilateral patient or not. His most recent monitoring only showed left temporal spikes and terta. Basically delta waves on the left side, a sign of abnormality in the temporal lobe. And his seizures, I forget how many he had, but they were all of left temporal onset. So from the video EEG standpoint, we're pretty happy that he had left onset. His neuropsych showed impairment of his verbal memory. I didn't pull his results, but again, that kind of is it's a concordant finding. He had an MR showing left mesial temporal sclerosis pretty clearly. And you will see these folks where if you follow them for a long time, maybe they start out MR normal, and then over years, he had this for 20 years, one side gets smaller. But this is just sort of, I think this is just a T2. But again, on the left here, you can see his hippocampus looking pretty small as you get back to the body. Architecture looks a little lumpy on that side. Not too bad. And we did end up doing a PET. So this is an interictal study. So you do this, it's an FDG PET, but it's a nuclear medicine study that you do when they're not having a seizure, hopefully. And the side that's affected generally has less perfusion. And so you can see on the left here, a couple of slices, the mesial temporal lobe. You don't see as much color. And it's a fairly qualitative study, actually, but you kind of squint, and is one side darker. This one's pretty clear as far as things go. And so he was, we discussed him at conference. We talked to him. Generally, for dominant size, we've been going with the laser first. So there's always the choice: do you do a temporal lobectomy or do you do a laser procedure? And if you look at outcomes, the temporal lobectomy does better, just in terms of seizure freedom. It's obviously a bigger surgery. You're not placing a catheter, but you're taking out, doing a craniotomy and taking out temporal lobe. So in terms of our algorithm at the UW, we generally, for the left side, we'll do a laser first and kind of not really talk about the temporal lobe as much, lobectomy as much. For right side procedure, just non-dominant side, I generally give the patient all the information about the two and just leave it up to them. And so I do have a sizable number of people who, even though you can do this and be out of the hospital in one day, they want the extra 20% or so chance at seizure freedom, so they'll do the bigger procedure and want to get it over with. But in his case, we discussed a laser ablation with him. And actually, he'd been discussed previously, actually, as a surgical candidate before we had this procedure, and didn't want the temporal lobectomy. And so just went on with the seizures. And again, this is one of the big advantages of this procedure, is that you have a fair number of people who've been told either by another center or whoever that your seizures come from your dominant temporal lobe, you shouldn't have surgery because you will never talk again, or your memory will be terrible. You're not a candidate for surgery. And one, that's not true. And two, with this, actually, the cognitive hit they take is even less. And so he's one of these sort of fortunate, fortunate for us, and for me and for him, but we talked to him about an occipital approach for the laser ablation. When you're doing this, I mean, we almost always go with an occipital approach the first time around in terms of aiming for hippocampus, because again, the trajectory gives you the greatest chance of ablating a length of hippocampus that's likely to get you seizure freedom. But that's one of the things you consider. So you're looking at the anatomy, and it's you have basically a one-dimensional treatment, but you're treating a three-dimensional structure. So you have to account for the curve of the hippocampus, where the catheter starts and where it ends up as you're pulling it back, because that's how you make your lesion, is you place a catheter all the way to the front of, hopefully, the head of the hippocampus, part of the amygdala. You create lesions and you pull the catheter back. And you're doing a straight line there. So the laser, one of the selling points is that the light or the heat doesn't cross peel boundaries. And so you do get a little bit of a curve that you see when you're making these lesions in patients, but you're not going to be able to make a C. You're not going to get all of the hippocampus. You don't really have to. But it's helpful to look at the coronal and sagittal views. You want to consider the vasculature in the region. So it's usually a fair distance within the brain that you're traveling, 10, 11 centimeters. You don't want to cross something big. So in terms of ways we avoid that, I usually get, if they have a really good T2, I'm okay with using it, but I'd like to get contrast imaging. You can see vessels, cortical vessels, to avoid them. I like to avoid crossing sulci on the trajectory. You will be near, choroidal fissure and carotid arteries that comes in. Generally with the laser, you don't have to worry about that too much with a large vessel like that, because there's high flow through there, and it basically acts as a heat sink. One of the complications of that is if you're really close, it is a heat sink, so you're not going to actually get a big lesion at that point. You'll see some of these lesions where you have a sort of like a snowman effect around near where the anterior choroidal is, because that's just pulling all your heat away. I like to avoid the occipital horn if I can. Sometimes you can't, but anytime you're entering and exiting ventricle, it may deflect your catheter. You have a chance of intraventricular hemorrhage. We've also found people tend to have more vague complaints like nausea, headaches, not really quantifiable if you're heating ependema for whatever reason. The other things that I consider, I try not to be too low. If you even though this is supposedly not crossing peel boundaries, you can end up heating and taking out part of the entorhinal cortex. In some cases, that's good because that is epileptogenic, and again, more brain you take out, the better seizure outcome you have. But especially on the left side, if you do that, people tend to have the classic left temporal post-epilepsy operation where they're having difficulty with memory and words for a few days. Sometimes it doesn't come back. So I tend to try to avoid doing that if I can. Obviously, you want to avoid the temporal stem, the roof of the ventricle, all the structures that run there. And again, if you go too anterior and you have a chance of getting Myers loop as it comes around, and you give them usually just an upper field, upper right, upper contralateral upper quadrantenopia, which is fine, but if you don't have to, there's no reason to do that. So in terms of how we do this, again, we'll go through this in more detail in the lab, but this is done under general anesthesia. The way our ORs are set up, we put the frame on up in the CT scanner, get our stereotactic scan, go down to the OR. Implantation, we use the CRW, so you can see the CRW here, use the gun sights, typical sort of straightforward stereotactic implant. The one thing is, as an occipital approach, it's sometimes less convenient. You can either turn the patient lateral or you can have them sort of in a semi-sitting position, just because otherwise you're going to be sort of on the ground trying to go up, which doesn't work that well. The laser catheter itself, once you have this is a terrible picture. I also stole it from Medtronic. So, but basically the way you secure the catheter usually outside the frame. So there's a bolt that you use as your stereotactic device. And so you pass the catheter in, get secured to the scalp, and then you go up to MR and you confirm your location. So this is this gentleman, I was relatively happy with where this ended up, but you can see how hippocampus curves and you get as much of it as you can. And again, taking into account those other things. So that can sometimes limit how far back you get. It can sometimes limit, usually what ends up happening is sort of the head of the hippocampus is in the most lateral part, and so you kind of want that, because usually it's the anterior part of the hippocampus, the amygdala, where your seizures are starting. So if you don't get as far back, I usually say, okay, that's fine. I'd say most of the failures that we have is usually leaving too much stuff up front. So that's one thing to keep in consideration. In terms of the MR ablation itself, you can see here these animations. It should be going. There we go. On the left side, you get the phase temperature map, which shows you your change in temperature, and then you get the damage estimate on the right side there. And that orange is supposedly all the tissue that you've killed. And like you said, you can see the lesion here. It's pretty round. As you move the catheter back, you can kind of connect these little round lesions, and you get something that looks like that. Yeah.
When you do this, you're putting the probe in down the OR.
We put the probe down in the OR. So there's two transfers. You start in CT, you put the frame on, you transfer them down to the OR, you put the probe in. I use fluoro to just make sure we're in the neighborhood. We go back up to the MRI scanner, do this lesion, get your post scans, and then usually we just extubate right outside the MR and kind of time it. Yes. You go back down to the OR. Actually, you don't go back down to the OR. What you do is you pull the catheter out, you put the frame back on. CT's next door to MR, so we just go to CT, put the frame back on, get another scan, go back down. So that's happened one time out of all the cases that we've done, so it hasn't been a huge deal. We've started using, well, I don't know what Jeff does these days, but I've started using the O-arm before I come upstairs to the MR, just because we're there. It's pretty easy, and you can tell where the catheter goes. I still haven't had to move it. It's pretty, I mean, this is a lot more forgiving than DBS. You know, if you're off 2 millimeters, again, you kind of look like, well, okay, am I going to be in temporal stem when I make this lesion? No. Okay, well, it's probably fine. If you're a little low, I usually don't mind. You can make a bigger lesion to go up. It's harder to go down, I think. In terms of things that you can get in trouble with doing this, we use a PMT bolt. It's a titanium bolt that's broken a couple of times. So you don't tighten it all that much to put it in, but we've had several, and apologies to the PMT people watching, but it's still your fault. If you tighten it too much, like the resident really cranks it in there, wants to get it real secure, you go to undo it and you'll just snap off the bolt. And then you got to go back down to the OR and drill it out, which is embarrassing. It doesn't hurt the patient, but it's you get a slightly bigger incision. There are a lot of ways where we can make this more efficient, I think, and I'll talk a little bit about it at the end, but the placement hasn't been too much of an issue. Once you're done, you get just a post-op MR to confirm your lesion, and I usually find the coronal flare is most helpful because, one, it gives you the catheter trajectory. As you go back, you can see here we're basically staying within hippocampus. I should have put his previous scan up next to, but you can see it kind of follows hippocampal sulcus, the lesion. I mean, I know it's round anyway, but you don't get a ton of spread into interrhinal cortex. And then once you get back here, you stop. And then again, in terms of catheter placement, you can kind of sneak it right under the ventricle most of the time. So in terms of why do we even bother with all this, it is kind of finicky. I'd rather do a temporal lobe any day too, because it's more interesting. But this is sort of the standard reference, at least for right now. But from down at Emory Willie and Bob Gross, they had a series of 15 procedures, 13 patients, so they did redo a couple of them. 9 of them had mesial temporal sclerosis. Follow-up at this point was pretty short, but 2/3 of folks with mesial temporal sclerosis were seizure-free. Overall, about half the patients were seizure-free, and one important thing is in terms of recurrence, at least up until 14 months, and when if you don't recur early, you tended to have a durable effect. We have more patients now. I think there's something like 300, 400 patients total in the U.S. who've had this done. But again, accruing follow-up time is the hard part here. One of the more interesting outcomes sort of justifying this is, well, one, obviously, it's a shorter hospital stay, lower complication rate. But this approach spares your lateral temporal cortex, your entorhinal cortex, so your cognitive outcomes are better. And this is just looking at dominant side surgery in particular. the bar graphs there. The blue lines going down are open temporal lobectomy, so you see a drop in their Boston naming scores. The green are the laser patients that they did in this series. So people decreased maybe a little bit, but somebody got a lot better, which is interesting. But you don't see that big drop in their Boston naming, which again, with the open temporal lobectomy, you tend to. Just for us, in terms of, we have 36 adult cases where we have more than 2 years follow-up. Again, we've got more patients, but they're pretty recent. 31 of them had mesial temporal sclerosis. 5 of them had like a DNET or a ganglio or a normal MR. In terms of an angle 1 result, kind of matches with what they had down at Emory. So about 2/3 of folks, and most of them were the people. I mean, most of the patients were MTS, but again, it's about 2/3 seizure freedom, and the other results. It's interesting, actually, the younger patients tend to have worse results. And so if you look at, I know one of our residents presented recently at a PEDS conference about doing this for pediatric patients, and everybody in the audience was like, oh my God, you have like a 30% success rate, it's terrible. So it doesn't work very well in kids for whatever reason, and the pathology may be different. But younger folks tend not to do as well. In terms of complications, that I didn't list all of the nausea, headaches, and things like that in a more detailed paper. We would obviously go look at those. But in terms of things where we were like, gosh, what happened? At least for these 36 folks, there was one small pulmonary infarct, which I think, and actually it didn't show up on the MR. This was like 4 weeks afterwards. The patient went into the neurologist and was having some strange neuropsych findings, and he got an MR then, and that was 4 weeks afterwards, and there was sort of a acute stroke, and so it happened probably about 2 weeks after surgery, and it was just pulvinar, just real small, and so I'm thinking maybe the lateral posterior choroidals or something like that, just heat damage that then ended up with thrombosis. But it wasn't something near the lesion. And then we had one patient who was in the Times, actually. He drove his car off a bridge on his birthday, about 4 weeks after, not 4 weeks, 4 months after one of these. His seizures didn't change at all. We were like, you should come back, we'll try again, or we'll do a temporal lobectomy. He's like, oh, no, I think I'm fine. I'm doing okay. And he died. So just in summary, the sort of points to take out is that this therapy creates predictable lesions. So if you see it on the MRI, you're pretty sure that's what you did. It's less risky, it's less invasive. Sometimes it's faster. Again, with all these transfers, if you're worried about things, you can't use the OR for something else, because if you need to take out the bolt, you can't do that in the PACU. So if you're thinking about running an efficient OR, this may not help you so much. It takes about 4 hours to do temporal lobectomy. This takes maybe 3.5, so it doesn't save you that much time. You do need a CT and MRI on the day of surgery, so you're moving patients around. Scheduling is an issue for us. We try to schedule these like 2 weeks in advance, because otherwise our MR techs lose their shit. They get all upset about this. Trying to do it urgently. In terms of epilepsy, it is a little bit less efficacious in open procedures. On the other hand, you can do this more than once, and you can still do the open procedure afterwards. So we do have a couple of patients where we did the laser, they didn't get better, they got better for a couple weeks, and seizures started up again. You work them up again, you look at the MRI, and most of the time, again, you see a little bit of hippocampal head left, or maybe some more amygdala, and you can just slide the catheter back down. You can even use the same tract and get a little bit more, and it hasn't been, in terms of how well it works, the ones that I've done 2 redo lasers and 2 temporal lobectomies after a laser, and so far all of them have been seizure-free. So it doesn't seem to alter whether or not down the line you have a worse outcome. So any other questions?